Okay, so in this presentation, I want to talk through some practice questions that I've created for board prep for NPTE for the 2020 boards. We are after many people have taken the May boards, but I think those will still be relevant to some of you who will be taking it in July. So my goal with this presentation is to just gain experience with some of the content and practice some test taking strategies and eliminating questions or narrowing down question answers, and then practice some of the clinical reasoning related to different areas of PT. So quick disclaimer, I'm not stealing questions from anywhere. These questions are similar to concepts that show up on practice questions, but I did write all these questions, so they're original work, and none of them reflect the actual test or published practice questions. So just have to throw that out there. All right, so first practice question. Question number one, you're seeing a patient with complaints of numbness and tingling in her hand, and you're performing tests to try to differentiate between a median and an ulnar nerve lesion. So these particular tests would indicate the likelihood of an ulnar nerve lesion or ulnar nerve pathology. Number one, the OK sign test. Two, the Froment's test. Three, weakness of flexor carpi ulnaris muscle, both 2 and 3, so positive Froment's and weakness, or both 1 and 2, so positive OK sign, Froment. So might be able to see the notes on that. I'm going to try to avoid that, but then as we talk through it, we'll give you the answer. So thinking about ulnar nerve versus median nerve pathology, we're trying to think about and differentiate between motor function of these two nerves, sensory distribution of these two nerves, and then some of our special tests that are trying to differentiate between functional movements, perhaps, that are influenced by these two nerves. So the OK sign, making an OK sign with your thumb and second digit or pointer finger, that's testing function of flexor pollicis longus and then also flexor digitorum profundus for the second digit. Both of which are controlled by the median nerve. So the K-sign test is a median nerve test. Froment's test is more of a pinch grip between the first and second digit where the adductor pollicis is involved. Adductor pollicis is innervated by the ulnar nerve. So Froment's test or Froment's sign is actually an ulnar nerve sign. So 1 and 2 cannot be true. Both of them cannot be true for the one nerve. And specifically, we're looking at ulnar nerve tests. So we're going to nix 1, and then also 5 is wrong because number 1 is wrong. The flexor carpi ulnaris muscle is in fact innervated by the ulnar nerve. So for this question, the best answer is going to be both 2 and 3 for ulnar nerve. And again, the OK sign test is testing median nerve. More specifically, though, you could think that that OK sign is testing the anterior interosseous nerve, which is a branch of the median nerve, which innervates those two muscles that we mentioned, flexor pollicis longus and the flexor digitorum profundus. So a related question is asking about posterior interosseous syndrome, which anterior interosseous, we're thinking affects the median nerve. However, there is a branch of the median nerve. The posterior interosseous nerve is a branch of the radial nerve and is going to supply muscles of the wrist and thumb, so thumb extensors and select wrist extensors. And so pathology of posterior interosseous could include, and you can think about the deficits that might be true for that. So I'm going to let you go through on your own and have the bonus of having this question to kind of puzzle through, but that's what we're getting at with posterior interosseous nerve. We're talking about a branch of the radial nerve. Okay. Question number 2, you're seeing a patient who has just gotten his cast off and he's 8 weeks post distal radius fracture. So it's a covinated radial radius fracture, had an ORAF, so fixation. He reports an 8 out of 10 pain with most motions. When you inspect his wrist and arm, you see that the skin looks shiny, there's swelling, some redness. He has pain to light touch over the dorsum of his wrist and all throughout his forearm. You are suspecting, based on these things, that 1, the fracture hasn't healed well, so you may want to do surgery to repin the break. In other words, fixation isn't working, you need to go back in. You suspect early onset CRPS, complex regional pain syndrome. Are those signs and symptoms indicative of CRPS? Do you think so? Or you suspect routine healing for this stage after RF surgery, so it's 8 weeks post-op. You expect some of these things, some of the swelling and redness and inflammation. Or do you suspect infection and you want to refer back to the physician or the surgeon? So what do you think based on the swelling, redness, pain to light touch, 8 out of 10 pain, 8 weeks after fracture? Do you have thoughts on this one?
I would say that's not routine.
Okay, so you're ruling out number 3.
Mm-hmm. And
what might indicate for you infection? What are some signs and symptoms of infection?
Like that redness and like heat to the area.
Okay, and what time frame are you most concerned with infection post-op?
I would say that's probably a lot earlier on than 8 weeks.
Okay. Some indications of maybe inflammatory process infection, but the time frame gives you.
I would say 1 would be more likely.
Okay, so the fracture's not healed well. So he was in a cast.
1 or 2.
He just got his cast off. He's been in a cast for 2 months. So think about that. So you're between 1 and 2. What's your evidence for 1? What's your evidence for 2?
Well, then if he's been in a cast for that long, then he probably couldn't have done much that would have like messed up whatever they fixed.
Okay. And then what do you know about CRPS or complex regional pain syndrome? What would be maybe some signs and symptoms of this condition?
I have to go back and look at that one.
Okay.
Because I don't remember.
Okay. If you were to choose an answer, so you think definitely not 3, that maybe the time frame is off for 4, you're between 1 and 2, you're doubting a little bit on 1.
Then I'm going to pick 2 at this point.
So not knowing or not remembering about CRPS, you're going to pick 2. And in fact, you're right. So complex regional pain syndrome, these are findings that are very characteristic of CRPS. So CRPS can develop after trauma or surgery, or it can just be insidious onset. However, some of the signs and symptoms that are very characteristic include significant pain. So he's an 8 out of 10 pain, and pain disproportionate to the injury or the stage of healing. So he's 8 weeks after the fracture. He should not still be in that significant amount of pain based on the stage of healing. Redness and swelling are also characteristic. So CRPS is an autonomic nervous system dysfunction, typically characterized by these different criteria of signs and symptoms. Diagnosis is made via the what's called the Budapest criteria. So you can look that up if you're interested, but it's characteristic of these things that we're seeing in this patient. So very significant pain. It doesn't match the stage of healing. Swelling, allodynia. So in other words, he has pain, just a light touch. The sensation or stimulus that wouldn't normally cause pain is inducing pain. Hyperalgesia, trophic changes, which changes to the skin, including shininess or color changes. So he's demonstrating these changes. So we can suspect CRPS. It is a diagnosis of exclusion, but that's what we're thinking based on the presentation.
I remember, like, I knew the hyperalgesia part, but I didn't remember the hair loss and the shiny skin part.
Yeah.
Of that, yeah.
Okay, so good. So even not remembering CRPS, some of these question elimination strategies are really effective. I think you did well with ruling those out. And then our bonus question on this one, if you're evaluating a patient after fall and outstretched hand injury or FUSH mechanism of injury, what are the most common areas of fracture in the upper extremity and exam findings that might clue you in? So I'm thinking specifically 1 at the wrist and 1 in the hand.
So like the scaphoid would be a common fracture.
Good. And then how about at the wrist?
And then the radius.
Yes, distal radius and scaphoid. Perfect. And what would be some clinical exam findings that might make you suspect those things if somebody comes in after this fall on outstretched hand? Where might you palpate for these areas of fracture?
I mean, like right in that whole area. Like in the snuff box area.
Perfect. So anatomical snuff box would be where you would locate the scaphoid for palpation.
And then the radial styloid, like right around that area.
Yeah, perfect. So distal radius, you got it. So these are the question choices, but you nailed it. So you got right to it. So scaphoid fracture and distal radius are going to be your most common upper extremity fractures with a Fuchs injury. So snuff box tenderness for scaphoid. You could palpate the distal radius. You may also suspect for radius fracture some limitations in supination and pronation range of motion due to the radius contributing to those forearm motions. And just to note, even with x-ray imaging, if you have a clean x-ray and suspect still a scaphoid fracture, this is a commonly missed fracture on x-ray. So it might necessitate repeat imaging, even if you don't see it on the first go. Good. All right. So question 3, you're seeing, talking about fractures again, potentially, you're seeing a cross-country runner with suspected stress fracture at the right distal fibula. She has brought in a copy of her x-ray and asked that you review them with her. She has been having pain for 2 weeks and now is having 8 out of 10 pain with walking. If her x-ray report does not show a fracture, what would you advise her? She probably doesn't have a stress fracture because it's clear on x-ray. It's okay to keep running as long as the pain is not too bad. X-ray may be inconclusive due to the short duration of symptoms. Monitor symptoms with activity restriction, and if necessary, potentially proceed to further imaging with a bone scan. She probably does have a stress fracture. X-ray can't detect it, so just tell her to stop running. Or x-ray is inconclusive at this time, so advise her to get a repeat x-ray in a month.
I would probably say 2.
Okay. How come?
Because stress fractures aren't always super obvious on x-ray if it's really recent or really small, like that might not show up. And that it hasn't been that long, so she shouldn't be, but with the pain level she's at, she shouldn't be running on it. So activity restriction seems like that makes sense at this point. And then yeah, maybe get a further x-ray later if, to give it some time.
Mm-hmm. Yeah, excellent. I think you're absolutely right. So we know stress fractures don't always show up on imaging early on. It might take 2 weeks up to 3 months. And oftentimes you're not actually seeing the stress fracture itself, you're seeing callus formation. So you're seeing indication of healing from that fracture, not necessarily the stress fracture itself. If you were to suggest an alternative imaging technique that may be a little bit more sensitive to detect a stress fracture early on, what might you suggest?
I forget what the other one is. Is it a CT scan?
So typically we're thinking for bone, either a bone scan, which is going to be
MRI. Okay.
metabolic activity of bone, where you can see hot spots if there is pathology in bone.
Bone scan, like a DEXA scan kind of scan?
Yeah, so a nuclear imaging scan. So it will be an x-ray with tracer. So really somebody will orally ingest a nuclear radioactive substance, like a bolus of fluid, with some sort of radioactive nucleotide. A lot of times, one I'm with is technetium that they'll use for a bone scan. And then they will image that individual, and the tracer uptake is dictated by metabolic activity of the tissue in question, in this case bone. And so
it's going to show a lot of metabolic activity.
Yeah, so there'll be more highly metabolic activity in areas of injury that the body is trying to repair. And so that could indicate stress fracture pathology. There's, in the literature, some will use MRI as another way to detect that. Bone scan is cheaper, so it's usually done. There is a contraindication to nuclear imaging, in which case MRI is preferred because it's active. So something to keep in mind for stress fractures. Good. Okay, so question 4, you're evaluating a patient who fell on his head after attempting to dunk a basketball in a recreational basketball game. He went to his doctor, who diagnosed him with a concussion and gave him a PT referral. In your evaluation, you may expect to see with this individual for concussion signs and symptoms. VOR dysfunction, saccades and smooth pursuits are impaired, but no emotional effects. So brain could be a brain insult, no emotional effects. Second, sleep dysfunction, sleeping 10 to 11 hours a night, head and neck pain, but no VOR dysfunction. Excuse me. 3, emotional ability, impaired balance, but not oculomotor dysfunction. Or VOR dysfunction, oculomotor dysfunction, may expect some light sensitivity and sleep dysfunction. What do you think after concussion may be expected?
I could see like the light sensitivity part and the like I feel like head and neck pain could be part of it.
Mm-hmm.
So I'm leaning toward those, number 2 and 4. Okay. I don't remember where VOR dysfunction plays into concussion.
So that could be kind of the deciding factor. 4 has VOR dysfunction, 2 has no VOR dysfunction.
Right. But I imagine also potentially sleep dysfunction as well.
Mm-hmm.
Did I see that? I didn't say that.
And why don't you think 1 or 3?
Let's see. I wish I knew more about his concussion. Why I don't think 1 and 3. I'm picking 2 and 4 based on the things that I do like recognize.
Okay, that's totally fine.
Rather than ruling out 1 and 3.
Okay. Yeah, so things that look familiar or when you're close to it or to. Okay. So let's go through this a little bit. So concussion has sometimes been described as a mild traumatic brain injury. So depending on the areas of the brain that are affected, you could have a wide variety of impairments for concussion.
Right.
Usually what I will do is I will break them down into categories and say that people can have signs and symptoms or impairments in 4 big categories. And that keeps me, and then I can start filling out those different categories for specifics. But I usually, I remember it by SPEC, the spec. I don't know why that sticks with me. So sleep dysfunction, physical impairments. So sleep, physical, emotional, and cognitive. So all of those things are fair game and probably expected with concussion. So going to answer choices, if I'm starting to rule out or take off things, emotional effects I can expect to see. So 1 I would take off right away. And then some of the physical impairments that I could see, again, they're going to be based on the area of the brain that's affected, but you could probably expect to see some frontal lobe dysfunction. In other words, we said emotional dysfunction, sleep dysfunction, but also vestibulo-ocular dysfunction is very common. And so oculomotor dysfunction for 3, you could expect to see. So 1 and 3 go away right away. The other thing that could be affected, because we said vestibular, is VOR. So we do want to test the individual for VOR. So we're going to go with answer the most correct, because VR dysfunction is a possibility. And these are some other impairments that you might expect from concussion in those 4 categories.
Do you mind hold on for just 1 second so I can hand this baby off to somebody else? Thank you. Okay, sorry.
So we would probably expect some impairments from each of these categories. Sleep dysfunction, some photophobia or phonophobia, so sound or light sensitivity, usually vestibulo-ocular complaints, fogginess, headache, emotional lability. All of these things could be appropriate, or not appropriate, but noted after concussion. I will let you answer the bonus question on your own. So this is kind of a follow-up, but noticing all those different areas of impairment, starting to think through what some appropriate treatments might be in physical therapy to offer to this individual within your physical therapy toolbox and skill set, and then what are some concussion-specific outcome measures. So I'll let you kind of work through that one on your own. We'll move on to a different topic. So, gotta get better at this. Okay, so got a neuro question. So you're working with a 34-year-old male who's been diagnosed with MS, multiple sclerosis. These are all things that you would expect to work on in your PT sessions. Patient education on fatigue management and regular exercise. Fatigue management, strength training, balance training, medication adjustments as needed. Number 3, patient education on fatigue management, strength training, balance training, functional movements like sit to stand or transfers, or indicating MS is mostly managed by medication, so there's very little impact of physical therapy treatment.
I'm going with number 3 because we don't deal with medication. And also, MS is not only managed by medication. Physical therapy can do a lot for MS patients. So, but fatigue management is really important, and functional movements are really important in keeping them going, even as the disease progresses. So,
awesome, you got it. That's fantastic. So I think your reasoning was excellent. Medication management is likely important. You might be discussing this with your patient as far as what the effects of medication are on them, but you have to be careful as a PT not to advise on adjusting it. That's not really our scope of practice. So you got it totally spot on with that one. What might be some precautions in patient education that you would want to be specifically thinking about if you're working with a patient with MS? So you hit on one of them.
What was that? The fatigue management?
Yeah, fatigue is huge with these individuals. So patient education on fatigue management.
I think, isn't use of heat contraindicated?
You got it. And why would that be?
That's a good question. Forget.
Yeah, so you're spot on with the fatigue management. Individuals with MS oftentimes have heat sensitivity. It's been described as Uthoff's phenomenon, but a difficulty in cooling themselves. And so a lot of times with MS in physical therapy, we're utilizing cooling strategies for these patients. So before exercise, during exercise, after exercise, cooling strategies are really important because of their impaired ability to self-cool and their tendency to become overheated. So drinking cold water, drinking ice water, placing ice packs or cool towels on their neck or head, fans, all things like that can be helpful. We're working on activity pacing, monitoring fatigue, talking about energy credits with these individuals for the day so that they aren't blowing through their energy stores and just totally wiped out for the day or the next day. Utilizing rest breaks within our Therex, prescriptions and functional movements. And then potentially, if appropriate, patient education on potential autonomic dysfunction or respiratory dysfunction. If there are cognitive deficits, we might want to gauge or adjust our instructions to these individuals. And then I didn't put this in there, but MS is so broad as far as the impairments that are possible because it is a central nervous system demyelinating disorder and progressive. As you noted, depending on where in the central nervous system is affected, where in the brain, whether it's spinal cord or brainstem or cortex, cortical MS, where these lesions are, that's going to dictate impairment depending on the function of those different areas. So these individuals could have widespread impairments, and one thing that could be included in that list is some sort of balance or vestibular dysfunction, and so maybe fall risk prevention would be the other thing that might make this list as far as safety or precautions. Okay. Next question. A football player presents to your clinic for a PT evaluation after being referred by his athletic trainer. He suffered an injury to his right lower leg after a rough tackle the night before in a routine practice scrimmage. He complains of pain at the front of his shin, and you notice that he is dragging his toes when walking towards you. As you examine his leg, it is bruised, significantly swollen, and he tells you that it's been numb since early this morning. Your best next step is to 1, tell him to perform RICE techniques, rest, ice, compression, elevation, and keep in touch with his athletic trainer. 2nd, suggest he go to his PCP this week so that he can rule out a fracture with an x-ray. 3, suggest he go to his PCP to rule out fracture with an x-ray and recommend PT as well. Or 4, send him immediately to his primary care physician or urgent care because you suspect his symptoms need urgent attention.
I would say 4 because he's dragging his toes. I mean, the swelling is also concerning, but in combination with that and the numbness, but it seems like there could be some nerve damage if he's dragging his toes like that. So I would be concerned that there might be something that needs to be done sooner.
And does this cluster of findings, the signs and symptoms, suggest any particular diagnosis to you based on mechanism and how he's presenting?
Since the morning. Is it like compartment syndrome?
Ah, very good. Very good. So this individual has signs and symptoms of acute compartment syndrome. So he has trauma, he has swelling, he has indications that anterior compartment of his lower leg neurovascular compromises. So as you mentioned, the neuro indication is loss of motor function, so dragging toes, and then numbness as well. Yeah, absolutely. So you want to get this individual seen. If somebody does have an increase in compartmental swelling because of the fascial compartments in the lower leg, anterior lateral compartment, posterior compartment, they're fascially separated. And so if there is acute injury, that swelling can cause an increase in pressure, which will compromise neurovascular structures. If the pressure is not relieved, you can have permanent damage to those structures. So it's really important with this sort of injury to seek immediate care if you have this kind of devolving or severe neuropresentation or impairment. So that's really good. And then what are the hallmark signs of acute compartment syndrome? So I remember it by the 5 Ps acronym.
5 Ps.
You remember these?
I don't remember.
Okay, so I'll help you out. So pain is 1, so severe pain. Pallor, so pallor indicating whiteness or loss of blood flow, so compromise to the vascular structures. Paresthesias and paralysis, compromise to the neural structures. And then pulselessness is another indication that some of the vascular structures are compromised. That pressure, that increase in intercompartmental pressure has cut off blood flow to the area. So your dorsal pedal pulse or potentially tibial pulse could be decreased or absent. Something also to note is that anterior compartment of the lower leg is the most common place that you will have compartment syndrome. So this is not unrealistic for this individual to be having an anterior compartment complaint. Okay, question number 7, you're working with a patient who was diagnosed with Parkinson's disease 2.5 years ago. You notice that the patient has much better performance in physical therapy when you see her in the morning. But when she comes in for afternoon sessions, she has noticeably more bradykinesia and sit-to-stand, so slower, and freezing of gait. You believe that this is common in those with Parkinson's. They often demonstrate a 24-hour pattern to symptoms and are often better in the afternoon. Or secondly, you suspect that this is an indication that the disease is progressing because she is not stable in her motor function. She's getting these fluctuations. 3, you suspect this may be due to medication on-off times, and ask her about what medication she's taking and when, especially if she is taking carbidopa-levodopa. Or 4, you suspect she needs to pursue further treatment with DBS, deep brain stimulation, to treat the symptoms that she is having in her afternoon sessions. What do you think?
I'm going to go with 3 on this one, because that is common with Parkinson's patients, that when they are on an off time for their medication, that they're going to have worse freezing of gait and generally just a harder time with motion, like smooth motion.
Yeah. Absolutely, you got it. So it doesn't necessarily mean the disease is progressing. 24-hour pattern, not necessarily. You suspect that this may be due to a medication on off time. Even though you can't make recommendations on medication, you do want to know how it's affecting her. And so it's appropriate. You can ask her about what she's taking and when to give you an idea of hypothesizing whether it is kind of an on-off phenomenon. And as patients take carbidopa-levodopa longer, and as the disease progresses, you will often experience these off times or wearing off of medication and increase in motor symptoms. So it's not uncommon. What symptoms for an individual with Parkinson's, so follow-up question, would you expect to respond to this carbidopa-levodopa medication, and what symptoms would not respond as well that might be addressed further down the road with deep brain stimulation treatment, surgically implanting that device?
It's my understanding that the meds are more going to treat like the freezing of the gait and I think like the festinating gait, stuff like that. But the deep brain stimulation is going to do better with like the tremors.
You're on it. Say no more. That's exactly right. So tremor is often recalcitrant or potentially resistant to carbidopa-levodopa, or it can stop responding. So there's inconsistent response for these individuals. If tremor is their most debilitating complaint, that may be an indication for DBS. So, yep, you're exactly right. Excellent. Okay. So question number 8. Here we go. You're working with an 86-year-old female patient, status post right total hip replacement, THA, total hip arthroplasty, who is post-op day 2. Based on what you know about precautions after a THA, posterior approach THA, your patient education includes the following. 1, no walking until 2 weeks after surgery because of this joint replacement. Don't cross your legs, don't raise your knee above your hip, and don't let your toes point in. Or 2nd, don't cross your legs, don't raise your knee above your hip, don't let your toes point in. And we're going to be teaching you how to walk with an assistive device. Or don't cross your legs, don't raise your knee above your hip, don't let your toes point in. Rest in bed as much as possible so that that area can heal, but walking's okay for activities of daily living.
I always get this mixed up and I have to think about it. Posterior approach is the old way. And anterior approach is the anterior lateral approach is the newer way of doing, or the more preferred way now with fewer precautions.
Yes, true.
So,
what are posterior hip precautions? We'll start there.
Definitely the don't cross your legs, don't raise your knee above your hip, don't point your toes in.
Okay.
I know all those are.
So that's all patient-friendly language. What do those translate to in our terminology?
So we don't want to adduct the hip. We don't want to flex the hip above 90 degrees.
Mommy,
We don't want internal rotation of the hip.
And why are those things important as you're educating your patient?
Because we don't want them to dislocate their new hip.
Got it.
And I just forget when they're allowed. I know with the anterolateral approaches, we're getting them out of bed really soon. But I forget whether the posterior approach is any different in terms of allowing them to walk.
Okay, so envision yourself in acute care, post-op day 2, if this individual is still in the hospital, and you're trying
I'm gonna say 2.
Okay, excellent. So you're trying to discharge them home. We're all about early mobility and early activity with physical therapy. So yes, they did have a joint replacement surgery, but likely, unless they have some other precaution, just with the posterior approach hip replacement, we're going to try to get them up and walking as quickly as we can so that we can safely discharge them home, ideally with an assistive device for walking. But these individuals should be weight bearing as tolerated. Resting a lot in bed without activity is not necessarily indicated. These individuals will be a little bit pain limited, but we want them to be active throughout the day in small bouts as they're able to tolerate it. So yes, we have these precautions to try to avoid dislocation or risk of dislocation, but we want them normally being active pretty early post-op. Let's see. So follow-up question is on precautions after lumbar fusion, laminectomy and fusion. So I'll kind of let you go through that one on your own. Spinal precautions. So it's a related question, but I don't think it's overly difficult. But just to get you thinking through that, you can go through that one on your own. And then let's move on to, I want to get to these last couple questions here. So question number 9, you're working with a 45-year-old female who had a right mastectomy 1 month ago. You're treating her for right shoulder pain and limited range of motion, but you're also managing her swelling and upper extremity lymphedema.
Down from you.
Is having significant
Can
swelling.
I have the orange one? Because there's
We have a young student joining our call.
Here, Maggie, take it.
How wonderful.
She just wants to play with all of my study materials.
Start them early, right?
I want all your colored pens.
Our patient is still having significant swelling. It's very visible in her right upper extremity. And as part of your treatment, your PT treatment for lymphedema management at this stage of care, you will likely perform. Missing word in this question too. Okay. 1, multi-layer compression bandaging, manual lymph drainage, MLD, active range of motion and use of the limb as she's able. Probably too early for compression garments, as the limb size will likely change with the wrapping treatment, and you will not be able to get an accurate fit for the garments because she still has so much swelling. Or active range of motion, manual lymph drainage, not necessarily compression. So compression is unnecessary. Your motion is ineffective. So active range of motion should take care of most of the swelling that she has at this point. Or 3, you want to do compression bandaging, manual lymph drainage, Therex for shoulder strengthening, because she's likely going to have some muscle atrophy. So that is going to be your priority with treatment.
My instinct says number 1.
Okay, talk me through that. Why do you think number 1?
I mean, her mastectomy was pretty recent. And if she's got the lymphedema, we need to work on getting that fluid out of her arm. But I feel like I remember the part about the compression garments, like wanting to wait to order compression garments for them because of that, because early on it's going to be so much more significant, and to work on getting the swelling out before ordering them.
Okay. So that rings true for you. What do you think about?
But I do think she probably needs to do some strengthening too.
Okay. So 1 month out, which treatments are you really prioritizing for this individual, do you think? How much pain is she going to have? What stage of healing is she going to have after a mastectomy? What's the scar going to be like?
You tried to move your
I need you to go and color, okay? And my mommy, let me do this, okay? Sorry. I mean, her incision should be healed at this point. But she's past like the 21 days. So yeah, I think yeah, I think I mean, I don't know. I'm having a hard time.
Okay, so your gut was number 1. That was what you were going with. I don't want to talk you out of that. I think your gut instinct was right, especially because as she presents, she has a significant amount of swelling. And the other thing that this question really prompts is that your main goals or your main treatments right now are the shoulder pain, limited motion, and swelling management. So based on those goals, it doesn't say anything about strengthening. You are exactly right to be thinking in your head that part of your ultimate goal as a PT is to try to get her strong for functional activities. But within this question, it's prompting you to treat more specifically her pain, range of motion, and swelling limitations, which are all going to be addressed with treatments in answer 1. Does that make sense?
Okay, yeah, that makes sense. That's a good like tip for looking at the questions.
Yeah, so it's a test taking strategy. So in your head, you're like, Therex, that's my wheelhouse as a PT. Well, yes, it totally is. And yes, an individual may come in a month out where you're working on some light strengthening. However, in the question, the main goals for this individual don't include anything about she's not demonstrating weakness. Your goal isn't to strengthen at this point. There's no complaints of functional limitations due to strength deficits, but really your priorities are addressed very well with the treatments in answer 1. So Therex, you're right, later down the road, but maybe not right now for this person. So that's kind of the explanation. I think we talked through a lot of that. kind of a memorization or terminology question for related to lymphedema. So physical therapy treatment for lymphedema usually will consist of parts of or all 4 parts of complete decongestive therapy, what's termed CDT. And these 4 parts are, do you remember these?
I don't.
Okay, that's fine.
I probably will once I see them, but like, I can't think of it off the top of my
Yeah,
head.
part of why I put it is just as a prompt, just to become more familiar with these again. So these are going to be skincare, the MLD or the lymphatic drainage, the light massage, lymph massage, compression garments or wrapping, depending on what's appropriate at that stage, and then decongestive exercises. So those are different parts of CDT that are likely indicated for these patients. Just a terminology question. And then our final question or content is pediatrics. So you're evaluating a pediatric patient who is 6.5 months old, whose parents are concerned about his development. So the child is sitting on his own, but has not yet started to crawl. He can demonstrate supine to prone rolling, prone to supine rolling, sometimes reaches for his feet when in supine. You conclude based on this that this is an appropriate level of motor development for his age, so 6.5. You can educate the parents regarding this and tell them they can monitor how he acquires different motor milestones, but there's really no need for PT at this time. Or number 2, you're concerned that this child has some developmental delay. He should be crawling by now, and so you deem him appropriate for PT to work on motor skill acquisition. So trying to teach him some of those building blocks of crawling. Or 3, this child should be rolling and sitting, but crawling may be a bit later. But since the parents are really concerned, you can go ahead with PT and try to accelerate his motor skill acquisition. So PT is perfectly appropriate, even though you don't really suspect delay. We want him to get him to crawl. His parents want him to crawl. Let's go. Let's do some PT.
I'm going to pick number 1.
Okay.
Because I've just been looking at all of this because of my little one. But yeah, I mean, those are pretty much, I mean, he should be reaching for his feet. He should be doing supine to prone rolling. And some kids don't crawl right at 6 months. They might be a little bit later. So, you know, I think he's within the normal range. So we're not going to do PT just because parents want him to develop a little bit faster. Maybe give them some tips on things that they can do to help since in this first appointment or in this eval or whatever, but I probably wouldn't see that kid.
You got it. I think you're spot on. So motor milestones, he's meeting his motor milestones. You would expect that he would be rolling, exactly what you described. He may not necessarily be crawling by 6 months. So just as a prompt or a way I tend to simplify these for my own thinking for peds developmental milestones, I try to break it down into what should they be doing at 3 months, 6 months, 9 months, 12 months? What are the kind of big highlights of the motor development? And that keeps me a little bit organized as I try to remember these motor milestones. So I'm just going to give you these because you did such a good job talking about that. I think you're right on with this, but we're really expecting at 3 months that the child is rolling by 3 months, by 6 months that they're sitting, and by 9 months that they're crawling. So really within that 6 to 9 month time is opportunity for developing that skill. And then usually by about a year, standing and walking are appropriate for what we would see with motor development. Okay, well, excellent. So based on those different areas, I know it's hard to touch on everything, but hopefully we jumped around a decent amount.